and you can as well as see the slide also. If anyone is online, kindly drop a message in the chat box so that we can proceed with our discussion. So I welcome you all to today's discussion of NEET-PG. We are going to do the physiology recall questions. So if anybody is there online, I guess my voice is clear and you are able to see me also. So welcome you all from ADRPLEXUS. Today we are going to see the NEET-PG Physiology Recall 2025. Okay, I could see your chat box also, so you can put your messages there so that I'll be able to address your queries then and there. So first of all, why do I have to attend a recall session? First thing is you can know the correct answers. That is one thing. And next thing is some of you might be preparing for the upcoming exams. For example, INI-CET is coming up. Then the next year NEET is going to come up. And I always say this one thing. The questions formation might be different, but the area where the questions are asked, that pattern almost always look similar. That's how we are able to predict most of the questions as faculties and your guiding forces. So first thing, coming to the number of questions asked in physiology, it was around 5 questions. And how many of them are directly from the workbook? We got almost all 5. So that is a good thing for us. So whosoever has attended the offline classes or online classes in ADRPLEXUS with respect to physiology, all of them are direct questions. And out of these 5, 2 were image based question, and 2 of the images we discussed in class, exactly those images came in the exam. So that's a very good thing for us. And so the strike rate is 100%. And some people, there is some recall of one more question also, so 5 plus 1, but I am taking it 5 because both are very similar questions. Some of the questions it will be difficult to recall, but both of them I have covered it, but I have kept still 5 questions. So let's begin with question number 1. So they have asked at a particular point, so since it's a recall question, so the exact question might not be there, but almost very similar question might be there. So this was the graph shown here, and many of the students confirmed that it is the exact graph from our session. So here they have shown the length of the sarcomere on the x-axis and tension developed. And they have asked a simple question at point B, what is the length tension relationship? So point B is here. So somewhere around 2 micrometers, and what is the length tension relationship? And they have given the image there. If you go and see the original image of this, it is given on the right side in the image itself. So it's a very simple question, I would say, for those who have seen this image. And as you can see here, at point D, the length of the sarcomere, always say x-axis and y-axis matters. That is the most important thing. So at point D, as you can see here, the length of the sarcomere must be really, really long. So at this point, there will be no actin-myosin proper interaction. So option A is ruled out. So at B, as you can see here, this is nothing but our actin filament, and the centralmost core is our myosin filament. So this will correspond to the point D. So that is not our answer. Next thing, coming to the point A. Point A is the shortest distance where there is actin-myosin kinking happening. It is seen in the option D. So that is not also the option. Next thing, we have 2 closer options, and I guess this much closer option was not there in the exam, but still we will try to discuss it. In these 2 options, there is adequate, in both of them, there is adequate actin-myosin interaction. So both of them can be correct. Out of this, the B is having a little lesser length. For example, if you come down, I always say, take a point and bring it and cut it across x-axis and y-axis. And point C. Out of this point B and C, you can see the distance is more in case of C, which is here. As you can see, the actin-myosin distance is more here. If they have specifically asked for the point B, then the best option would have been, according to this example, it is not B also, the C is the exact option, because it is little lesser than in comparison to the C shown here. But most of the students told that the diagram was very much easier to do it, and they have asked what happens in this point. So in this point B and C, there is adequate actin-myosin interaction. So that is the answer. And this diagram, according to this question, the correct answer is C in this option. So was it there in our workbook? The answer is yes. And many of the times I tell the students to revise the quick shots. And in our sessions, we always have 300 quick shots which are given at the end of the workbook. And many times I jokingly tell almost all the questions might come here. This time also 4 out of the 5 questions have come from this quick shots. But ideally you have to listen to the class so that you can clear with the quick shots. And there is a question bank, the leaderboard question also we have put across these type of diagrams. So coming to the workbook image, this is an exact image as you can see here. and exactly the option D, there the length is too much, and option A where there is kinking, and B and C could be the proper actin myosin interaction. And below also we have written the optimal length is where the maximal tension is observed, and optimal length for a skeletal sarcomere is 2 to 2.2 micrometer. So if you have seen the image, it is a very simple question, but if you are seeing it for the first time, then it might have been a little tricky. Next, coming to the next image based question. This image based question, for students who have attempted the class, they would feel that it is a very easy, but in general this is considered as a little difficult graph. So what does this graph say? Here they are saying the point in the VQ graph. What is VQ? VQ is nothing but the ventilation, and Q is for perfusion. They are asking where does pulmonary embolism is indicated among the various points. They have given point A, B, C, D, E, and normal they have given C. So definitely it's not a pulmonary embolism. So in C, it means that the PO2 levels, the x-axis says PO2 and the y-axis says PCO2. And the PO2 levels is around 100 mm of Hg, which is normal in an alveolar air. And PCO2 at point C, the PCO2 is around 45, which is in the normal alveolar air. Now they are asking for a pulmonary embolism. First, you have to understand what happens in pulmonary embolism, then only you can crack this question. In pulmonary embolism, there is no blood flow. So out of the ventilation and perfusion, you guys know that the perfusion is not happening. So what will be my ratio? My VP ratio. First, you have to understand this concept. The denominator is 0, so the ratio will be infinity. When the perfusion is 0, so this is one concept. Next thing is when the perfusion is not happening, what is going to happen in the alveoli? In the alveoli, now what is not happening? The perfusion, the blood flow is not coming. So blood is stopped. So it will exactly reflect the alveolar air. So it will exactly reflect the alveolar air. So that is important. So what is the normal alveolar air? The normal alveolar air, we have O2 around 149 mm of Hg, or 150 you can say, and CO2 is very negligible, so 0. So I have to find a point. So first thing I have understood, the VP ratio is 0, so the ratio is becoming infinity. Next thing is when the pulmonary perfusion is not happening, it is going to mimic exactly the air, the atmospheric air. The atmospheric air we have alveolar, the atmospheric air now it will equilibrate with the alveolar layer. Alveolar. So the O2 is 149 and CO2 is 0. So where is the O2 149? You have to keep on traveling here. Here it is around 150. So this is point, and PO2 is 0. So it is going to be our point E. So this point E, as indicated in our option D, is the correct answer. So this exact graph we have it in our workbook, and side of the workbook we have written it clearly. So it was there in workbook, and in quick shots we have given that the PE ratio is infinity. The VQ ratio is infinity in pulmonary embolism. If you have understood this concept also, you could have been able to crack it. And what is a point A? Maybe in the next INI-CET they might ask you point A. What is a point A is whenever the ventilation is cut off. So when my ventilation is cut off, what is going to happen? Whatever venous system blood is coming, that is going to equilibrate with the alveolar air. And what is the venous system PO2 and CO2? All of you guys know. The PO2 levels in the venous system is 40 and PCO2 level is 45. So maybe the next time they can ask you in a patient who is having an obstruction of the alveolar pathway or the upper airway is obstructed, what is going to happen? They are going to come to point A. But for now, our answer is going to be point E, and the correct answer is D here. So let's see if we have this image. This is the exact image which we have it in our workbook. So, and we clearly indicate the most important aspects only. So I always say keep your workbooks neat and clean. So as you can see here at point B, the PO2 is 150, PCO2 is 0 mm of Hg, and we have just written pulmonary embolism. So this is an exact question that we have given it. An expected question, I always say this area is very much expected, VQ ratio. Then the VQ ratio infinity, that is also given here in the shots, quick shots, and shunt mechanism. This we have also done it in an MCQ in a leaderboard questions as well as in the workbook. So when you're doing the class as well as the quick shots, especially for physiology, I would say you should always have a look at it. Then if you're able to work on the in-class leaderboard as well as the question bank, then you would have cleared it very easily. So those were the two image-based questions. The next question, This question was easy, but the problem was you guys were not given pen. I have heard that that is a very sad thing to happen, because ideally questions like these need a little bit of help with pen and paper. So let's see. So, but right now try to understand the concept. They have just asked if the net movement of the capillary should be zero, net movement should be zero, then what should be the interstitial hydrostatic pressure? So there are four pressures which are called as Starling forces. We discussed this Starling forces, and I told you that it is going to happen both in case of the capillaries and blood vessels as well as the renal system, like the Bowman's capsule. So what is going to happen? There is one pushing force, that is a hydrostatic force. Have they given the value? Yes, they have given the value as 18 capillary hydrostatic pressure. And capillary osmotic, so it is in the other direction. So it is 27. And they have given interstitial osmotic pressure. Interstitial osmotic pressure means it will pull the fluid towards it. That is 7. Then they have asked you what is the hydrostatic pressure which is pushing. So this is our X. So here there are two forces which are in one direction, and another two forces are in the opposite direction. They are saying it should be 0 finally. So 18 plus 7 is equal to 27 plus X. So as you can see here, it is 25. So it is obviously 27 minus 2, I have to put it. So the correct option here, according to this question, is 2 minus 2 mm of Hg. This concept is there in our workbook. Yes, it is there. And this concept is also called net filtration pressure. That what is the end filtration pressure? It is there in the quick shots also. There I have given just the values, but the original question is having a lot of values here, which we have done it in the workbook. And we have done question banks is also having this type of question. The exact question might not be there, but similar questions are there in the workbook as well as in class leader book. So next is, this is a same diagram from the workbook image. Here, the one of the pressure was 0. Why? Because this, in a Bowman's capsule, there is no protein filtration happening. So that's why it was 0. Other than that, two forces are, one force, the 60 is coming like this, and other two forces are going like this. One of the force is not there because there was no protein. So according to here, 60 minus 18 minus 32, which was 10 mm of Hg, is the net filtration pressure when you see it in the glomerular filtration. But the concept is same. The concept as was Starling's forces. So there will be four forces. Hydrostatic will be pushing, and osmotic pressure will be sucking or pulling type of forces. And net filtration pressure in the glomerular filtration is 10 mm of Hg. So this concept is important, and values, once you substitute whatever the value they are going to give you, you will get the answer very easily. Next, coming to the question number 4. This is the longest time I have made it. So a 30-year-old trekker is ascending, and finally he is developing high altitude cerebral edema. So finally the end point is high altitude cerebral edema. It is really fascinating that most of the times in question paper, so my suggestion is please make a note of this question for future exams also. Why? Because they commonly ask something called as high altitude pulmonary edema. I'll tell you the reason also why high altitude pulmonary edema is commonly asked. But this time they have asked much a simpler question, that is high altitude cerebral edema suspected. What is the primary underlying mechanism for this condition? So increase in intracranial pressure due to cerebral vasoconstriction, that is not the reason. Low PO2 mediated vasoconstriction. This, whenever there is hypoxia, this will happen only in the pulmonary system, not in the cerebral system. Cerebral vasodilatation secondary due to low arterial PO2. So this was the correct answer. And the arterial, high arterial H plus, with the help of CO2, if they are forming a lot of CO2, they can cross the blood-brain barrier and stimulate the chemoreceptor, central chemoreceptor, with the help of CO2, which is getting converted to H plus. But as such, cerebral vasodilatation is not going to happen. The commonest cause is nothing but hypoxia. So what is the difference between the HASE and HAPE? The reason for developing edema is different in both of them. That's why they are interested. That's why I tell in the class also. In hypoxia, it will cause vasodilatation. Remember the statement, hypoxia will cause vasodilatation all the vessels except pulmonary. So usually they ask the exception, but right now they have asked the cerebral directly. Hypoxia will cause vasodilation. That's it. This is a very simple question. So it was there in the workbook. It was not there in the quick shots because in the questions we have pulmonary vasoconstriction question. So once you understand these two difference, then we could have easily cracked this question. So coming to high altitude cerebral edema, In high altitude cerebral edema, what is going to happen? There is hypoxia, and this hypoxia is going to cause vasodilatation like it does in all the organs. So this was a simple question. But my suggestion is please pay attention to the next part also. You might get it in the INI-CET. Hypoxia will cause something called as HPV, hypoxic pulmonary vasoconstriction in pulmonary system, and it will cause stress failure. So the first one was due to vasodilatation and capillary leak, which we have mentioned it clearly. And the second one is due to high pressure. Now there is vasoconstriction in the vessels because of the right ventricle now trying to push with high force. It will cause something called as stress failure, and finally a leak. So both these concepts are important. There was one table in high altitude physiology. We are also amazed to see that two questions have come from the same table. So this is the lower half of the table. Now we'll go to a question which is on the upper half of the table. Same table. Next, going to this was the question. Some of the students recalled a question similar to this. Some of them recalled a direct acid-base balance question. So let's see this first question. So somebody is climbing to a Mount Everest, and during a climb, he experienced shortness of breath, headache, and mild dizziness, with improved over a few days. Like, what is the most likely acid-base disorder in this individual? When somebody is ascending to a high altitude, the first response their body will do, that is nothing but hyperventilation. Whenever somebody is doing hyperventilation, there is a CO2 washout. Because of this CO2 washout, if CO2 is not there, what is going to happen? It is nothing but respiratory alkalosis. So it is a very, very straightforward question, respiratory alkalosis. So it was there in our workbook. It is there in our quick shots also. Again, quick shots I stressed upon, especially for physiology. And some of the leaderboard questions also we have discussed a similar thing with respect to respiratory alkalosis. To compensate it, metabolic acidosis can happen, but the primary defect they are asking, that is respiratory alkalosis. So as you can see here, it is the same table on the above section. Here we have mentioned there is an increase in pulmonary ventilation, increase in CO2 washout, respiratory alkalosis. To compensate it, metabolic acidosis can happen. Is it there in our quick shots? Yes, hyperventilation in high altitude. There are only 300 quick shots, and as you can see here, the weightage, hyperventilation in high altitude causes respiratory alkalosis. Very simple. So there was some more recall from the students. Some of them, they said that there was one high altitude question and one ABG where they asked a direct finding, like what is the primary disorder they have asked. And primary disorder, some of them recalled as respiratory acidosis. I'm not sure about the exact question. I have compiled it in such a way, but again, acid-base balance, whether it is physiology, whether it is medicine, always it is important. I keep on saying acid-base is really a value for money, always important. So first is pH, and I tell you guys with the simple technique, pH is like the queen in the game. So the queen, like we see in the game of chess, it is the most powerful piece. So whatever the pH says, that is the primary disorder. So first thing, what is the pH saying here? The pH is less. So the pH is saying here acidosis. If any option has alkalosis as the primary disorder, eliminate them. So what are the two options? Respiratory alkalosis I am going to eliminate, metabolic alkalosis also I am going to eliminate. There could be only two possibility, that it could be a metabolic acidosis or a respiratory acidosis. Next thing is whatever values are given right there. So PaCO2 is nothing but acidosis, respiratory acidosis. And next is bicarbonate. Bicarbonate is at the higher level, so it is called as metabolic alkalosis. Now, in this patient, we have respiratory acidosis as well as metabolic alkalosis. But what is the primary disorder? What is the secondary disorder? Whosoever is following the queen, I always say this, whosoever is following the queen, they will become the king. You just have to follow some queen, you will become a king. So the respiratory acidosis is following the pH. So that is the primary disorder. So the answer here is C, respiratory acidosis. What about the other one? It is a compensation with renal compensation. So it's there in our workbook, it's there in our quick shots, it's there in our leaderboard. A lot of questions we have done in the class also, as well as you must have got it in the question banks also. So this is one of the simplest question. So I have considered both the questions as question 5. Maybe there were two questions or maybe not. And this is the entire table. which we do, we play it like a game in the class. The pH is the queen of the game, and whosoever is following. And the example we have quoted here is alkalotic example. But respiratory acidosis, alkalosis, anything, you just follow this simple rules, you will get the answer. And if you go to the quick short section, we have made these 4-5 questions exclusively for faster revision of our final thing. So this respiratory acidosis, as you can see here, the pH is 7.28 and the PCO2 is 58. In the primary question, maybe it was 60, around 60. So here there was no compensation, but there is a renal compensation in the question that was given. So with respect to physiology, we are happy that all the questions were covered in the workbook. So we had a 100% strike rate. And 2 more questions which were relevant to physiology, but I have not put it here. One is the amiodarone they have asked, which is a potassium channel blocker. And all of you know that potassium is a repolarization agent. And they have given a simple ventricular action potential like this. And they have asked in which phase it is going to act. So all of you know that it is going to act in this phase by blocking the potassium. So that was one question. And in the medicine point of view, I think there was some recall question with respect to the higher anion gap. So whether it is physiology or it is medicine, always this is important. The acid base is important. So thank you all. I hope you have done the exam well. So make sure that you see all this recall based area, because high number of repeats can happen in the INI-CET exam. So if you have any doubts, I will be happy to take it. If not, we can wind up the session. So all the best for you all. Wait for your results. Don't get tense. Now it's time to relax. And if you're preparing for the next one, make sure that you go through these areas. They are high weightage areas.